Welcome to everybody who is joining us online, and members of the public who are joining us for the North West London Acute Provider Collaborative Board in Common. We will take questions from the public at the end of the meeting. We've had some submitted in writing. We will also take questions at the end of the meeting from people who raise their hand. So back until then, joining us online, if you members of the public, if you have your camera on, we can see into your homes. If you want to turn your camera off, then that would be fine. And just to note that we record this meeting for purposes of minute taking. So if you join us, you are therefore giving us permission to record your voice when you ask a question and record the inside of your home if you have your camera. So I have a few apologies from Bob Alexander, Aman Dalvi, Vanita Chanda, Syed Mohinuddin, Simon Morris, Balja Pipe, and Ian Bateman. I don't think I have any other apologies I'm aware of. Oh, very good, thank you. And we have joining us, we've got Michelle Dixon, the Director of Engagement and Experience from Imperial, for to support us through item 1.4, patient story, later on the agenda. So, do we have any declarations of interest that anyone from the board needs to raise with us? Okay, thank you very much indeed. Then turning to 1.2, the minutes of the previous meeting, are there any significant matters of accuracy that anyone feels need to get corrected? Now, if you find interesting spelling mistakes, you can share them with Peter. Fine. Okay, we will take those as accepted set of minutes, and I will turn to the action log. People who've got their names against action logs, is there anything that people feel the urge to update us on? We had the standardisation of the safeguarding reports. Janice, that I think that would be worth progress.
It is. I've got a meeting with Rory, I think later next week, because there are some changes with the changes in the ICB around how safeguarding is delivered by the ICB and by NHS London. And I think it would be prudent to have those discussions and then see how we go forward.
Brilliant. Thank you. And the clinical pathways programme, which is still outstanding.
Yeah, just in terms of the update on that, as you'll see from the action log, we've deferred the date. Well, we had a really helpful conversation at the last board in common around planning for what the next sort of stage of this is. So at the moment, we are still focusing on the implementation of the phase 1 of this programme, because we need to get that in first. Now we will now start to sort of turn our attention to what phase 2 looks like. So that's why we've pushed it back to January, so we can come back with some meaningful proposals around what that looks like.
Right, no, that seems very reasonable. Thank you, Peter. So I would like to now move us on to the patient story, which will be about our interpreting services. And Michelle, you were going to do a little introduction for us. There you are, Michelle.
Yeah, I mean, I won't add so much what's in the paper other than to say, I think it's quite important. This was a project that really came out of the pandemic. So it's sort of the same time we were collaborative across partners. We were also looking at how we're more collaborative with patients and the public. And it was probably the one thing that came out of the community engagement we started then, where they said, actually, you have to get this right. We don't believe that you really want to make your services inclusive, accessible to everyone if you don't make this basic, right? And so we've done a lot of engagement, a lot of understanding, and actually looked at the issues of safety, lots of issues of around access, but also efficiency. It's very, very inefficient the way that we do some of this stuff, and the lack of engagement adds to that. So I know that's been replicated across the Acute Provider Collaborative. Everyone's been looking at it. Now increasingly we are looking at work together, and I mentioned in the paper, well, the London Northwest are leading for the collaborative around one application, which is Card Medic. But the little video we're going to show you now is just some mainly stuff. It's quite difficult to get patient stories of people who feel comfortable to do this. We have one patient partner, Asmin Mana, who's become a patient safety partner, and her English now is, you'll see, is pretty good, but she wasn't able to speak English initially, so she talks about some of the time when she couldn't, and then mostly it's our staff, and we're talking particularly around a pilot started, and I think these this pilot, these machines which are interpreters on wheels, they're very, very simple and straightforward, but we didn't have them because we didn't know how important it was for staff and patients to have this sort of equipment. And at first the cost looked like it was the problem, but actually we found there's huge efficiencies to be driven out of using stuff like this because you pay by them. Anyway, I won't say any more. We've got Lorraine Brown, who is leading our interpreting programme online as well. And Lorraine can take any questions at the end once we've seen this.
Brilliant, thank you.
I'm not pressing anything.
Press something. Let you.
No, Lorraine was
going to.
Excellent.
They're just sharing now.
Yeah, thank you. I think that for some reason, some people couldn't see that video and other people could, but we will put it online for people who want to watch it again later, because because I'm logged in and I couldn't see the video, but I know other people who were online could see it. So apologies, but thank you very much for the this really interesting presentation. I'll just open up to questions or comments. Martin, please.
So I had a really interesting Sunday lunch.
Excellent.
And I met the guy who runs marketing for ASOS, which is a quick fashion show. And he said he employed 1,200 people, 100 of whom human, plus 1,100 of his people were actually chat. I'm really interested. I think they would go down a chatbot translation service. Do you think that'd be a bad thing?
So it's really interesting because we've looked and we are looking at AI, machine learning. There's until recently the national guidance for NHS England was to not do that because it's so different in terms of the nuance around what you're doing in a medical in a clinical setting. But now very recently the guidance has been much more take a risk, what we were trying to do anyway. So I think what we'll end up doing is I think you will need professional decisions about consent for operations, the kind of complexity of people's problems. At the other end, where those kind of the stuff that makes people feel welcome, we absolutely can use machine learning or AI to help us with some of that. So I think what we say in the paper is we're moving to a blended approach, and AI, machine learning will be a big part of it, but I don't think we'll ever replace. And in fact, I think what we're learning through the work we're doing is at one end you need people who are interpreters / advocates, because it's not just the language, it's the whole system that people don't understand. So I think we'll definitely use more, but it will be so.
Thank you. AJ, then Sim, then Pippa.
Thank you. Yeah, I'm sorry I couldn't see.
AJ.
I wasn't able to see the video.
We can't. One moment, AJ. We're not getting you through the microphone feed, because I'm going to come to Sim and then I will come back to you. Sim.
Michelle, thank you. Really important piece of work. And I'm just wondering whether you've been able to trial across several divisions, because we know in maternity that, disproportionate people language barrier is one of those things. So have you been able to trial and pilot this in maternity?
Yeah. So we've the pilot this for us is in maternity and ED.
Yeah.
And maternity being done, they've got looking at all the things come out of it, like having a interpretive plan within Cerner, some of the things changing that.
Yeah. Pippa.
I think this is brilliant and a great example. There's many examples out there. I think Martin's right though. This is advancing really quickly now. The new iPhones automatically translate for you. So patients are coming in and using their iPhones as well. So we just need to be clear on when we need real medical translation, and that has to be from consent. When you're taking detailed information like risk assessments that would change their clinical pathways. And then we need to be clear on when we can use more informed phones. So I think we just need to be careful that we don't go for an easy option that might not be the safe option. And we've got decisions, because there's lots of tools out there now. Patients are bringing themselves and just use it on their phone. So we need to just be clear on the safety netting around it, I think. And also we can't just make it a bot that's very impersonal. It has to be that interaction at some point with the patient on a long pathways. But I think it's a great example.
Thank you. Are we going to get? We'll give it. I'm going to give AJ a chance to come back in, then I'll come back to you, Martin.
Are you able to hear me now?
No, that's even. Keep.
I'm so sorry.
We got you. Fantastic. Yes.
Okay, so I'll give it a quick go. So I'm sorry I wasn't able to see the video. The question I had was about the being able to monitor and measure the rates of medication errors or emergency admissions, stages of disease at diagnosis, for example, for patients with limited English proficiency, and also I'll be able to track the number of DNAs and hospital admissions, readmissions, and patients with language needs, because I thought it might help us to also calculate the financial impact and have a clearer view of our interpreting services, whether they work or not.
It's a huge area, but we've started doing that, and I think there's much more work to do across the APC. So we've certainly done it through looking at incidents and doing much more monitoring of where that may have been a factor in an incident. And in the paper, that it just references a bit of work about capturing communications and additional needs preferences that we started, and that would include this in terms of language need. Because then if you can attach that, we can do that analysis. I mean, we do it across ethnicity, we do it across socioeconomic groups. We don't do it yet in terms of language need because we can't capture that information systematically and holistically. But that is a piece of work that's absolutely underway.
Thanks. We come to Martin and then Lorraine. I'm going to give you the last word on this, but let's, Martin, you want to do it?
No, I just wanted to say that I think tech in this is advancing faster than we imagined. So machines can speak in local accent. They can take the accent of the person talking to them and then speak back to them in the accent that they're hearing. They score more highly in empathy than humans do in most of the studies that are being looked at, and they're more patient. I think we are at the tipping point with some of this stuff, where actually they would be better at doing consent than the human. They then get fed up with explaining stuff. I think I just make the case.
I step up, and I think a lot of the patients we're talking about are probably having to copy documents by other organisations into whichever Google Translate in order to get, so they're used to using it in their own lives and probably being a little precious about it.
Yeah.
So, Lorraine, would you like to add anything?
So I think I agree that, there is opportunity to use AI and machine learning translation, but we've just got to be clear when we use it. And so at the moment, we know that for machine translation and AI, we can have a low risk clinical conversations, but for more high risk clinical conversations, we do need to stick to more traditional methods until technology has completely caught up with accurate translations, which is why that we're suggesting at the moment that we need a blended approach for interpreting for our patients.
Brilliant. Thank you. And thank you very, very much for your work on the project. I think it's important and increasingly important, and we can see in the work that we're starting to pioneer around inequalities in access that English as a first language is going to come out as a significant differentiator towards your outpatients, whether you're a DNA and so on. And the more we can do in order to take away that inbuilt inequality, the better our service will be, the better we can service our population. So thank you for this work, and thank you, Michelle, for bringing it to us. Okay, I'm going to move us on now to Chair's report, my report, which you have in writing. So, first of all, start by saying Happy Diwali to those people who are with us, and just to make the point, which we're all very aware of the increasing level of intimidation, both to our Jewish patients and colleagues, but also to almost anybody who's not the same as everybody else. So the pressure that's been coming on increasingly on our Black patients and our Black staff, patients from any of the global majority populations, which are a very large proportion of our staff and a very large proportion of our patients. And just make it clear that the NHS is dependent on the cultural diversity of our staff. And if we lose that, if we make it not a good place to work, either because of what's going on amongst staff or because of the way the patients treat them, you lose the NHS. We are absolutely dependent on the fact that we are a culturally mixed and skilled workforce, and these we as a leadership and as a board will focus very hard on anybody who betrays that trust. And I want to draw people's attention to a very powerful letter that was in the Observer a couple of weeks ago from one of our consultant surgeons at Ealing Hospital, Salah Abdallah. I put the link to London North West website, which is but she talks with enormous passion and pride about coming to the country as a child refugee and finding a home in the NHS, which allowed her to fulfil all of her talents. And now she is a consultant surgeon working in our hospitals. And we have innumerable examples of that across our organisations. And I thought important that we just flagged that at the top of our board meeting of our pride in those colleagues and our commitment to equity and inclusion and a fair NHS for everybody. So thank you to those staff who work to make the NHS that kind of an organisation. I also wanted to welcome our new chair of the ICB, Mike Bell, and our new chief executive, Francis O'Callaghan, who have started in the last few weeks of the new merged ICB that brings together North West London's ICB and North Central London's ICB. And then the only other thing I just wanted to highlight was that this will be Helen Stevenson's last board meeting as one of our NEDs. She has been poached to go off, and some of you will have seen in the papers, to join the newly football regulator that has been created. And for some reason, being on the board of the football regulator is more fun than sitting in our meetings talking about our budget. So I don't see it myself, but there you go. Thank you, Helen, for everything that you have done. Okay, and then I'm going to move on to the notes of the board in common cabinet. You have those in front of you. The cabinet exists to pick up matters that we need to address that come up between our full board meetings, and then we report it back to the full board. We reviewed our draft winter plans, which needs to be in with NHS England, and we looked and we talked about planning for next year. We don't yet have the next year's planning guidance, but we do have the framework for developing our 5-year plans, and we're working on that. I think that probably the rest of it is self-evident, unless any of my colleagues from that meeting think I should have raised something. Oh, okay. Thank you very much. In which case, I'm going to move us on to Peter is going to introduce the provider capability assessment, 3.1 on the agenda.
Thanks, Matthew. Peter Jenkinson, Director of Corporate Governance. So just in terms of the context and the papers, so we're going to the next paper actually introduces the national oversight framework and the methodology behind that. The provider capability assessment is a part of that national oversight framework, which has been introduced recently, and it requires each of the individual trust boards to complete an annual self-assessment against a set of standards around board capability. They then will feed into the national oversight framework and the regional view of each individual trust. So the process we have been through to get to this point is, you'll see in the papers that we have published, each trust has completed its own assessment against those statements, and you'll see a pro forma then for each of the individual trusts around whether we have been able to confirm compliance with each of those statements. Where trusts cannot declare confirmed, then there's a requirement to put in some narrative in there. But as you'll see from these papers, that all 4 trusts are submitting or proposing to submit a position of confirmed against all those statements. To help that assessment, each of the individual trusts have been through at their trust standing committees a thorough review of those statements, supported by some narrative. which you'll find in the reading room if people want to reference it. Those are the detailed statements that sit behind, and those are the statements that we will submit to Region to support the pro formas that you'll see in the papers. So each of the individual trust boards, Matthew's asked to approve their respective submissions that will then go off to NHS England.
Very good. Thank you, Peter. Let me open it up for questions. Carolyn.
Yeah, so the format that we've got here is a completely different format to the format that we had at our individual standing committees, and I just wanted to therefore understand that this actually reflects the conversations that we had at our standing committees.
So that's what I think. I hope obviously not explained very well, Carolyn.
Yeah.
So these pro formas are the output of the conversations we had at the standing committee. The detail sits in the reading rooms, which reflects the narrative that we've had against each of the statements in at each of the standing committees. This is the output which we agreed to say that we would be able to confirm compliance against each of those.
So if I could ask Leslie then, so the conversation that we had confirmed, if we'd said something was an amber green, confirmed is correct, therefore, yeah.
And the one with the amber greens and the caveats we've written against it, that's going up as well, isn't it?
Yes,
I didn't read that in the meeting room, so apologies. Yeah, thank you.
That's exactly right. Any other questions or comments on this? Mark?
Just one question as to the value of this. I'm just trying to think about if the trust that wouldn't, I mean, who wouldn't, right?
Yes.
So I think there's in many ways what this is asking is the trust as a body, is the board as a body understanding its responsibilities and what it might need to do about some of the issues that any individual organisation has, which is captured in the work in the reading room. In a way, this is confirming that it has been that all of those things have been discussed at some length, and the board is aware of all of it, is confirming it has gone through those different sections and discussed those things and understands what work lies ahead to improve or otherwise what needs to happen is how I would read that.
And what we're confirming are some quite specific questions which you can see in the reading room, like have your plans been tested against with your wider system partners and those sorts of things. So there will be places who can't confirm all parts of that, I suspect. Tim.
Yeah, I mean, I think this is a bit like doing your homework, and it's now gone to be marked. I mean, I do think that this is going to sit behind the oversight framework. It's going to sit behind because the oversight framework is going to be refreshed quarterly, so trusts will go up and down. The response that NHS England will make to that will depend on their assessment of the provider capability. So I think they will go through this and they will want to assure themselves the evidence that we've given supports the statements that we've made. And if they think they don't, then I think that will make them question things. So, which is why I think actually it's sensible to put the amber greens in rather than just the greens, because I think if you can demonstrate a degree of insight and awareness, it's probably a good thing.
Thank you. Linda.
And on a more positive note, I did actually find the conversations very useful as a non-exec director, because I think it did lead into challenging ourselves a bit about actually if somebody was asking me as a non-exec director, what do I know about all of these categories? It's actually quite useful to sort of challenge yourself, well, what would my evidence be? Where would I go for the evidence sources? So the exercise of doing it in itself was quite useful.
Very good. So I need to go around the individual trusts to get confirmation here. So first of all, can I ask the non-executives from Chelsea and Westminster whether they're happy to sign this off?
Yes.
Yeah, good. Thank you very much. Then I will ask for Imperial College Hospital whether the board members are happy to sign this off.
Yes.
Yeah. Good. And then London North West board members happy to sign this off? Yeah. Thank you. And then lastly, Hillingdon. Very good. Excellent. So those are all signed off. Thank you very much. Thanks for that, Peter. And you're on stage again.
I am, but I can't take any credit for this next agenda item. It's James Biggin Land Centre's apologies. So asked me to introduce it, but I think there's probably two parts to this. I think, Matthew, one is around the explanation of what the National Oversight Framework is and the methodology, etc., which is explained in the slides here, and happy to have that discussion if that is not clear. I think Tim just explained around how does it work around the metrics, and then the financial override and the provider capability assessment are all part of the whole system. In terms of individual trusts positions in there and the opportunities arise, and I defer to my CEO colleagues to explain around each of the trusts and where they think they are. But so I wonder if we take it in those two parts. Matthew, one is around, does everyone understand how it works? And if we do, then how do we then talk?
Quiz. Questions on content, David.
Thank you, Peter. Thank you, Matthew. I think what it does, it emphasises the emphasis that the government are putting on the money. Because actually, if you're not meeting your budget, you're straight away into oversight 3. And that, whether we like it or not, is a steer for us until they change their mind. Hence, I'm sure Chelsea and Westminster would absolutely be at number 1, but because that it purposely decided, to do things in the next quarter, it came out to 3, which was a shock to all, really, because it's an outstanding trust. So I just wanted to emphasise that point that people realise this is the direction that's been set.
Yes, I think it's an important point to highlight that there is a league table of a whole range of performance, and then there is a financial cut-off. And if you are not saying you're currently breaking even if you're saying you'll break even by the end of the year, if you're not saying that you are currently breaking, if you're going to break even, you start at category 3 and go down towards category 4, depending on your performance.
So I think it's also fair to say it has shone the spotlight, rightly or wrongly. You've got to pick some metrics on different patient safety elements. So it's absolutely shone the spotlight on infection control that you could argue as a board maybe we haven't had the right scrutiny over, but it puts 3 infection control metrics in there, which you'll see in it. It's also shone the spotlight around staff survey. Now, recognising 2 of these metrics can only change yearly because they're staff survey and their patient experience survey. But you would argue it supports the work we have been doing around culture and raising concerns and staff feeling their voice matters. Well, that's really important in this, actually, and as is the patient survey piece. So some of these will change quarterly. Well, the rating will change quarterly. Some of them we've only got an opportunity to change it once a year because they are driven off the national staff surveys. But it has shone a slightly different spotlight. Might be helpful.
Yeah, I think I'm rolling into a general conversation about it.
Do you want us to say something about our own? Is that what you're asking?
I think that's probably what the board would be looking for rather than just the message.
Yeah, so let me let the 3 chief execs talk about this, and then I will come back for general questions again. So, Tim.
I'm sorry, just one sort of nuance on the IPC. Realises that the IPC targets that we will have are set in a particular way. So there are a percentage reduction on the previous year's numbers. So they vary from trust to trust. That's the first thing. The second thing is that once you've blown it for the year, so that you can't recover an IPC score in quarter 2 or 3 if you blow it in quarter. So as Pippa says, there are some that you can't change because they're annual. There are some that can change, go up and down. And the IPC one, it's an accumulation of infections. And when you hit the cutoff, you flip out of category 1 and fall down the categories, and you can't recover that, even if you have no infections the following quarter. In terms of Imperial, I think you'll be unsurprised to hear that we were pleased with where we came out here. I think that we have got work to do. We've spent quite a lot of time, David's point about the money. I think people find this could be a bit of a moving target. I think these will change for next year. And one of the things that they are very understandably concerned about, something called what they're calling RONDA, the risk of non-delivery. And so there's a set of metrics they're looking at to see whether or not they think you're actually going to deliver the plan that you're saying. I think that will start to sit behind the judgments they make about the money. So I think we're obviously focusing to make sure that we are confident in our level of delivery for the end of the year. We've worked quite hard on that. Otherwise, I think.
Thank you. Firstly.
Thank you. So I think a couple of things is to say the framework came out after Q1 is one thing. The second thing that I'd say is, rightly or wrongly, we took a pretty purist approach to the financial plan, which was not do we believe we'll break even at the end of the year, but because we will, but actually a discussion that says how do you make that sustainable and resilient month on month with the within the organisation, and that is what has resulted in the positioning. I think that the financial plan has recovered in the following month. In terms of CHH, if it's okay, Chair, I'll just go straight on, which is in many ways that wasn't such a shock to us. But just to say this for THHs, that actually performance has improved. Patient safety, I won't add to my colleagues. And indeed, for the last financial recovery, that organisation, our organisation in Hillingdon, has worked incredibly hard to make that resilient and sustainable over the last few months as well. So I'd say thank you to them. But in the position and where we were at that moment in time, that's the reflection of where we were.
Thank you, Leslie. I mean, just to emphasise, we are all confident that Chelsea and Westminster will deliver break-even plan this year. It reported not breaking even at the end of the first quarter. If it hadn't done that, it would have come out as the highest performing acute trust in the country. And to have two of our trusts sitting in category 1 is very extremely impressive. Also, to talk about Hillingdon coming out to category 4, as you say, not hugely surprising, but disappointing that I think it was 3 places away from being a category 3. This is a league table. It isn't only how well you perform, but it is how well you perform relative to others. Of course, the next set of league table statistics have closed already because we are already past the end of month 6. So we wait for the next couple of, like waiting for exams to come out. There's nothing you can do now about these, but and now understanding it better. But the focus for Hillingdon to move it from a 3 to a 4 significant. There are things we can do. That's a fairly marginal move, assuming that the whole of the NHS doesn't dramatically get better over the next 6 months, which is probably a reasonable assumption. So lots of work to do, but I think there's no question that Hillingdon has come a really long way compared to where this would have been if we'd done this rating this time last year or this time the year before. So, and London North West.
Yeah, I mean, obviously we were very pleased with the 2. It's a massive progress looking at where this organisation has come from and moved to. We were one of 3 trusts, obviously Imperial being the other as well, that this trust that is in category 1 or 2, so that is fantastic. We know what we need to do to A, keep on track, and B, to improve. We know that our staff survey, our patient experience survey was really poor performing last year, and that has improved this year, so that will change in the score. We have done a lot of work and doing a lot of work to analyse the infection control metrics, which could score, but as Tim says, it's 12 months rolling, so that becomes trickier. So we completely understand where we need to get to and all stay into, actually, which I think is the right place for this organisation, a great place to be.
I think so as well, and I think it's a tremendous credit to London North West to come out in category. Again, we've done it 2 years ago. I doubt it would have been coming out category 2 there. It's a sign of real progress. We need to watch these numbers and manage them whilst not getting overexcited with every report, because usually the NHS publishes stuff annually, and once you get your numbers out, you can either be impressed or celebrate for quite a long time. The fact that somebody has got cold press around their head and is working in the next set of league tables already, because these are coming out quarterly from NHS England, doesn't mean we're going to have to be looking on trends and progress rather than just the absolute positions. But I think it's been I'd say that James' absence, the paper is an outstanding piece of work of trying to explain a really, really complicated set of metrics, and I think putting it to the public domain, people have time to read it. We'll hope you understand what's going on every time this makes the front page of the newspapers every quarter. And I'm aware of a number of consultancy firms there who've taken James's work and are now packaging it so they can sell it back to the NHS based on us having stuck
I've
it.
even contacted him about it.
So yes, it's a really good piece of work. Right, any other questions or comments? Yes, please, Nick.
I had a quick one, because as you know, we've been talking in another place about what we're commissioned for in terms of electric recovery. And one of the challenged areas, or it has had a significant impact to overall schools, is our comparative performance on 18 weeks, 52 weeks, which is in the context of an ICB commissioning a reduction in overperformance for us, which means we are stuck between a rock and a hard place in terms of delivery towards that target, which is a challenge for us. I just wondered whether we can get that into a broader explanatory context. It won't change the numbers, I understand, but I think it's worth making that clear that it's not entirely surprising given the way we have been commissioned.
Let me take a few contributions, then I'll let them be wrapped up collectively. Mike.
Thank you, Matthew. So just to go back to the financial override position, which David said reflects the current focus, really. But so it does feel a bit harsh that thinking particularly about Chelsea and Westminster, that because it's the year-to-date position, you get an override and you get downgraded so significantly. But I think to echo your comments, we'll need to make sure we don't overreact to this. And I mean, I think a potential downside that start to, I'm sure we won't do this, but others will start to think about how they report on a year-to-date basis because of this. I think it's important we continue to maintain the quality and the integrity of the overall financial reporting. I think, looking at what's happening, look at trends, but let's not overreact. And your point, we're already past the second quarter, so de facto that means the financial override will apply again.
No sacking managers up at 39 days. So, Jazz and then Tim.
Yeah, I was just going to make the comment about foundation trust status and applications going in for that. I think the NOV scoring is going to be quite an important metric that they'll be looking at in terms of who goes first and what the outcomes might be. So it's important from that perspective as well, I think.
Yeah, thanks for that, Jazz. Tim.
Yeah, thank you. I just wanted to sort of pick up on that point from Mike. I think that the upside of this is that it's very clearly a rules-based system. So you know the rules, and the danger of that, of course, is it becomes a game. So you have to be really careful about that. And I think that we have to be quite clear that if we've got areas where we are looking to see an improvement, if we are seeing an improvement and we think the improvement is the right level of improvement, then we need to be satisfied with that effort, irrespective of what the NOF is telling us. So in other words, it would be ridiculous to try and ask people to do something that is completely unachievable just because it's going to switch the NOF. We've got to have a view of what an achievable target is, and it's got to be stretching, but it's got to be achievable, and then we've got to hold ourselves to it. And if that means that we go up, then so be it. If it means that we stay where we are, then so be it. If it goes down, then obviously put a bit.
Yeah, very fair. David.
Yeah, thanks. So from a patient perspective, there is a risk that this could be seen instead of, say, a CQC rating. I.e., that hospital is number 2, that's where I want to go. That hospital is number 106 and I don't want to go there. So I think that's something we need to be mindful of, and the knock-on effect it could have on staff morale as well. We've been working really hard. We're doing everything you do, and we're in segment 3, for example. So I just think whether they're intended or unintended consequences, we just need to think about the cons beyond the immediate result. Whether we like it or not, the public are going to see this and act accordingly.
Yeah, I think it's a very important point.
Yeah, I think the NHS England and the CQC are going to have conversations about the read across between CQC rating and because yeah, you're right. At the moment, you've got two ratings. The thing is, these are coming out quarterly, and at the moment, it feels as though the CQC are coming out quarter century. If you think about when the last time the full inspection was, you live with these aged ratings. You see, whereas this will be so I think it will be important. I completely agree with you about the messaging to our people has to be around the absolute improvement day on day, week on.
Very good. Thank you. Thank you very much for that. Thank you for that, Peter. Moving on. Okay, I'm moving on to the IQPR report, which has had further updates and developments, including the adding on the second page of it of a slide that captures the NOF frameworks, so you can see at a glance where our organisations are. But I also thought really usefully what needs to change in order for each of those things to move up. But this is an outstanding piece of work by James and by the information department. I don't see this anywhere else. I think it's a really, really smart piece of work. Does anyone want to add anything in the overview before I plough straight into the quality report?
Just to remind everybody that that all bits of this have gone to the individual organisations, and so this is, as we go through each bit of it, is to pull out the exceptional stuff by category.
Thank you. Okay, let's move into quality, and first of all, the performance report.
Page 60 of the pack, the overview, I'll stick with that. This has been scrutinised by Quality Committee. There is really nothing of concern that's outstanding in terms of looking at maternity and neonates. We've got a lower than the expected stillbirth rate and neonatal death rate and preterm birth rate, which is fantastic. Then if you go on to section 4 of that, again, we've got no concerns outstanding. We have made reference to infection control, and there was a lot of work that we are doing to really understand what we can do to change some of the infection control metrics. Not only belong in our hospital, they actually belong in our communities, and they have higher prevalence in some of our communities. So there is definitely some work with infection control, but actually our mortality rate is good. We've got 3 trusts that are better than expected and 1 as expected, which is great. VTE risk assessment is great, and patient experience both in maternity and in inpatients adults is positive as well. So really nothing outlined for quality. It's all a good set of metrics.
Thank you. I think the just noting the VTE position and how that has changed since we've deployed the electronic patient record, that is a example of a piece of IT that's been deployed, has improved the quality of care to patients, and having for both Hillingdon and London almost now to be up amongst the best in the country in terms of their VTE because of the help of the technology. It's just worth. It's easy to have the other view of when we would deploy this technology. Any questions or comments on the section? Okay, let me move on to the Learning from Deaths report, and John, I think you're going to take us into that.
I will, although Pippa has stolen my thunder, I think, mainly there, and I'm giving you the highlights in terms of the 3 different HSMR and Shimmy scores that we have. I guess just a reminder, this was the first of a new reporting period for HSMR with it's an increased set of diagnostic groups thrown in, which has affected Hillingdon slightly more than the other organisations. In terms of assurance, we continue to meet as a mortality surveillance group across all the organisations which I chair on a quarterly basis, and we go through those learnings from those, and we haven't found any areas of quality that relate to those slightly different scores in the organisations. And as a triangulation, we continue in every organisation as ever to do our level 2 mortality reviews and continue to find low numbers of cases with suboptimal care, which I think is helpful, especially given our overall low mortality, that we continue to provide the other layers of scrutiny. And that's it. Thank you, Chair.
Thank you. Any questions, John?
So are you saying that having looked at all the trusts, it's really the population they serve rather than the service that the trust gives?
So you're breaking up slightly on my connection. Can you say that?
What's the question again?
So what I was asking was, if you've looked at the variation in what is provided by the trust, there's very little difference. So are we to take from that the difference in Shimmy is because of the populations you serve, or?
No, I don't think I'm not. No, I'm not.
Say,
no, I'm not saying that. Sorry, the microphone in where you are is not coming through fully. But no, I'm not saying it's due to the different populations. I'm just giving assurance that we have checked the. I'm giving the assurance that we have then gone through where we have spikes in mortality. For example, at Hillingdon, the team have been through individually pulled case notes, for example, looked at the quality of care, because what we do is then double check that there is any clinical concerns or not, and none have been found in those. As to finding the causes of different, the kind of population differences, that's a very difficult ask, and nobody's ever quite, I think, got to the bottom of geographical variations, although you can see across the country it does vary as you go further outside of London.
Thank you. Yeah, I think the point to make about the in-hospital mortality rate is we have 3 trusts that are producing outstanding results. I think the last time I looked, we had 1, 4 and 8 in the country, which is sure. And then Hillingdon is what you would expect for a hospital like. The challenge for us is how do we make Hillingdon as outstanding as our other 3 trusts? It's not flagging a problem, but it's certainly, I don't think it can be just explained away by the population, because across our patch, we've got all sorts of different populations being served by different trusts, and so it's work. I think it's a thing we continue to focus on. Nick.
I actually did ask this, I think, in a previous board meeting, and I don't anticipate being the whole answer, but it does strike me that in terms of the number of investigations of level 2 at Hillingdon, it's considerably lower than the other trusts. And I know Chelsea does particularly more historically, because I remember that from when I was on the board there. But I do wonder whether a slightly higher number of investigations might be something that would lead to some of the answers to the question. If we do want to move from average to outstanding, then maybe a greater level of investigation would be an appropriate thing to do.
That sounds like one for you, Alan.
Yeah, and when that's been brought up, we've taken that on board. So we're reviewing the superstructure of our mortality review. So we've got a new Associate Medical Director for Quality and Safety, and she's been tasked with a full review of all mortality. I won't go into the full details of the work that I've set her, but the level 2 reviews is one of them as well. Thanks.
Thank you. Okay, thanks for that, John. Thank you for that report. And then lastly, on the quality section, let me just report back from the collaborative quality committee, which I stepped in and chaired in Pat's absence. Very good meeting. Couple of points that we wanted to raise to the board. One is that there is a delay on the new single reporting system due to some problems in the procurement process, which are being resolved. There's also, and this became a theme, was just a general sense of concern about needing more progress with a system-wide solution to mental health patients who are finding themselves in our A&E departments, and particularly in the run-up to winter. This is neither a good experience for the patients nor a good experience for our staff. There are better places for these patients to be cared for. And we asked for some pieces of work, some of which you've now seen. We asked for the deep dive on the NOF quality metrics, and particularly the focus on infection control and you will see the outcomes of that. So thank you for speedy response to that. And we've asked for some future reporting on mental health patients in A&E who are not appropriately, or the A&E is not the best place for them to be, and how that is comparing year on year, whether we're making progress, and also requested that the System Mental Health Group should do some more work on what the long-term solution to that issue is. Anyone got anything that to that? Okay, thank you very much indeed. Let us move on and come back to you, Pippa, the performance report around people.
So again, nothing really stands out apart from appraisals, and we've got a bit more work to do around appraisals. We have the single learning platform and the appraisal module on it of both London North West and Hillingdon, which will really help the capture of that. And Kevin's worked with Tracy to set the appraisal windows now. 3 months, so from next year, from next financial year, we'll have the same appraisal reporting window, which will help. But otherwise, of concern in the people metrics. The one that I do think is important to just pull out and have a short focus on is the model employer goals. So you'll see there on slide 95, we've got the model employer goals. So these are the goals of the proportion of your organisation that our BME member of staff is the denominator. And the percentage target then is different for everybody, because that's the percentage target that you should have reflected in 8A to BSN levels. We've all had some work to do on this. What you can see is there has been an improvement, a 3.7% improvement over the last 18 months, which is positive. That's largely driven by the improvements at London North West and Imperial, but every organisation can see the gap it's got to make to have a reflective senior team to its workforce.
Thank you. Any questions or comments on the people report? Highlight something, yes, please.
Yeah, I mean, it's more in the finance report and the finance section, but one of the other things that I've been working on is the reducing the pay spend and reducing the use of bank and agency. And you'll see there that we're hitting the national requirements, and agency reduced by 60% and banks reduced by 20%. So that's something that Common has been focusing on as well.
Thank you very much. Yeah, and that's a real progress being made there. Any other questions or comments? Okay, thank you very much. In which case I shall move on to the Collaborative People Committee. David.
Yeah, thank you, Chair. So a couple of points really. Everybody's got the paper to read, but just building on Pippa's point, we had quite a discussion. It was a good meeting, by the way. We had quite a discussion around the EI dashboard and debated the setting of annual diversity targets. Frankly, if we have a examination of any institutional discrimination, we don't necessarily have the data that tells us, more importantly, how we're improving, what we're doing about it. So there's a piece of work to do in that area, building on our previous best. The other thing I want to just touch on is really the point that Kevin's touched on already, is that the theme that's running through our people agenda is, on the one hand, how well teams have done to be more efficient, i.e. the amount of money we have versus the people that we have. But it's also highlighted that we've still got a bit of a gap. So we can't quite still afford, given the budgets that we've got, we can't quite still afford the number of people that we have. So great work's been done, but more needs to be done. And that really runs as a theme throughout this, whether it's our highest risk, whether it's the areas of focus. But I don't want to lose sight of the fact that how hard people have worked to get us to this stage. And I think, Chair, those are the 2 points I just wanted to highlight. Thank you.
Thank you very much. Anyone got anything they want to add or ask David about that? Okay, thank you very much indeed. Yes, we will move on to the finance and performance.
Great, Jameson, thank you.
Thanks, Leslie. So we will cover in the pack the August data set, save for cancer, which is the July report as normal. Worthy of note, inside the monitor data from the National Oversight Framework, we also have new metrics being added to the pack are key importance for the collaborative, and some of those metrics are equity guided measures that help us both monitor and reduce health inequalities. We, as ever, each of the chief operating officers and managing directors has a lead portfolio. I'll ask Laura to cover referral to treatment elective care. In Ian Bateman's absence, Mark Titcombe will cover diagnostics, I will cover cancer, and Sheena will kindly cover our UEC urgent and emergency care standards. So I'll turn to Laura to cover elective care and referral to treatment. Thanks, Laura.
Thank you, James. So we'll see from the pack that in August, our performance was at 59% against the RTT position, so a 2% increase from where we were at the start of the year. We know that we're working towards a minimum 60% performance across the APC by the end of the financial year, but we have some stretch targets within that we've referenced, with Chelsea having the highest at 67.8. In terms of long waiters, the number of patients waiting over 52 weeks has remained relatively stable, but again, we know we need to reduce that to no more than 1% of patients waiting by the end of the year. We've also been asked by the national team to make sure that we've treated the small number of patients that we have who are waiting over 65 weeks by the end of December, and are working through plans to achieve that, including any mutual aid between organisations if needed. The main challenge, I think, to flag, which we have touched on already in the meeting, is the impact of the ERF cap this year, which limits the level of activity that we can do or will be paid for. And that is leading to the overall waiting list growing, while we still continue to make good progress with the overall RTT position. Key areas of focus remain thinking about how we can do more around our productivity. So we are starting to see the benefits of the work that we have done on our clinic templates to create more capacity for new patients. We are continuing to increase the number of patients who we are discharging onto PIFU pathways, and we are undertaking a review of our advice and guidance with GPs and thinking through how we can better leverage this to reduce the number of referrals that come through to us. Thank you, James.
Thanks, Laura. I'll turn to Mark Titcombe for diagnostics, please.
Thanks, James. On diagnostics, you can see the August performance in the pack. So 24.4% against the allowance of 5% has been pretty stable over the past 4 months, and is broadly in line with both the national and the pan-London position for diagnostics. The key issues here are very much around ageing equipment, some modalities where there are difficulty in staffing. Both of those areas are being addressed, and there's plans in place, and also managing the overall demand for diagnostics within the finances and within the ERF cap. On the demand side, continuing to review that in terms of the use of decision support tools in primary care and in secondary care, and also work going on around our CDCs to make sure that we're making the best use of them where appropriate for this, recognising that they're primarily there as a community service for GP direct access. Thanks, James.
Thanks, Mark. In terms of cancer care across the collaborative, so the faster diagnostic system is compliant at the London-wide level of 75% and more, achieving at 79.7%. So really good performance against the FDI. We still aspire to get up to the 85% level, working very collaboratively with Royal Marsden Partners, our Cancer Alliance. A small improvement is needed at Hillingdon of 3% to get to the standard. They have specific challenges around lower GI and urology, which also reflects wider cancer performance when we come to the 62-day standard. Moving on to the 62-day standard, we are performing above the national London levels as a collaborative, but we do remain challenged at 76.1% against the 85% expectation. We have stepped up RMP meetings, our provider Cancer Alliance, at site and trust levels, in addition to our cancer boards, to really increase that focus on performance, particularly over the winter months. And as Laura wisely mentioned, particularly as each trust is managing within a defined level of activity, which we know can stretch cancer and elective care over the winter period. I will move to Sheena to cover urgent and emergency care. Thanks, Sheena.
Thank you, James. Morning, everyone. So just on urgent and emergency care waits, if I start with August performance for 4 hours, we were 77% against the national ask of 78%, slight drop from previous months at 3 of the trusts, and Hillingdon achieving this and exceeding it. Obviously, we want to do much better for our patients. So there is a increased focus on trying to see as many patients within the 4-hour time frame. We have seen an increase in demand at the front door, as well as delayed discharges that has prevented us from meeting that target in August. Each trust is obviously working through their UEC programs, and we're monitoring those almost every other day, if not daily now. On patients waiting over 12 hours, on the proportion waiting over 12 hours from arrival to ED has seen a slight increase at 4.1% from the previous month at 3.7%. Mental health remains a particular challenge across all our ED departments and overall is impacting flow. We are working closely with our mental health colleagues and our acute psychiatry colleagues to make sure we maintain safety of all patients in our ED departments and making sure that they do get to their destination in a safe way. Ambulance handovers from North West London continues to be good compared to London. August combined performance of completed handovers within 15 to 30 minutes increased. 49.6% completed within 15 minutes against a target of 65%, and 83.3% completed within 30 minutes against a target of 90%.
Thank you.
Back over to you, James.
You're happy to take questions.
Okay, let's take it section by section. So I just wonder if you'd like to say something about the new report on inequity in the longest waits. I think we've never had that report before. I've never seen a report quite like it. And I understand this is our first day to getting the data together. So data can be tidied up. I just wonder if you could share it about it. This is page 65.
Indeed, thank you, Matthew. I liken it to the way that we often monitor mortality in hospitals, with 100% being the expected range that you would see for treatment based on the indices of deprivation within our local community. So we can see that we are between just about the 95 and 105% monitoring period, with a small uptick across July and August. Within the stratification, you can see areas where the waiting list is perhaps higher in higher categories of deprivation in our population. So the stratification directs us to Chell West and Hillingdon as perhaps needing to understand a bit more about our waiting list, the way that we're serving patients, and perhaps targeting interventions in areas of deprivation as we go forward as a collaborative to make improvements.
Thank you. Leslie, do you want?
Yeah, so sometimes when you first try to bring together this data, it's part of the discussion we've had earlier around iterative and learning from what it tells us and telling us, go and have a look so you understand it. So I asked the board to bear with that there's, either we put nothing together, we're saying we're starting to have a look at this. It needs some work on it, but that's where we are.
I think it's very important. I'm really pleased to see it here. And obviously, it takes a while for us to crack how we're counting it and make sure we're counting everywhere the same. But I think once we cracked it, we'll move on to looking at other clinical areas with exactly the same analysis.
Yes, we should just say this is one of them. This is out of the work that we did when we made recommendations to the board that we should have some key metrics in all the domains. This was one of them. We've also got 2 quality ones that are just being worked through. You should see that in the next iteration, which is time to analgesia for sickle cell patients, and 9+6, and maternity women from a diverse background that have their first booking appointment by 9 weeks and 6 days. So they're the 2 metrics we're just also working with.
Great. Thank you very much. Okay, other questions? I think Helen, then Nick.
I just want to,
say that I'm really pleased with that work. The work we're doing in the National Community Fund on health is around looking at structural racism in relation to health and looking to try and address it from a different perspective. And I think that what I've been saying to them all the time is, real, boots on the ground. There's some real activity happening in trusts to try and address this in a very practical way. So I think the more we're doing on that, I think it's really very cool.
Can I just say one thing? Deprivation is probably one of the most consistent factors, I think, that we're starting to have a look at. So we need to be careful about it, that we can do this. There are a whole load of factors that we need to be clear about.
Thanks. Thanks, Charles. Nick.
Sorry, my point was about diagnostics. If you go.
We'll come to diagnostics in a minute.
About PIFU, is that okay?
Yeah, go on.
So it's just given how essential the whole outpatients piece is in terms of all sorts of our performance data. I just wondered, two questions really. How confident are we that patients understand what PIFU is, and what's our proactive communication around that? So resident, I haven't seen a lot really, but and then the second one is how confident we are that the structures within the trust to actually respond to that are consistent across the piece, and how are we monitoring that? That's three questions really.
Yeah, for our members of the public who've joined us, can you explain what PIFU is, as well as explaining whether people know what it is? I thought you had your hand up to answer.
I'm happy to. Yes. So PIFU stands for patient initiated follow-up. So the idea being that if rather than having a follow-up appointment where the patient may be completely well, and they come in and you say, how are you? And they say, I'm very well, thank you. And then they go, which is not always a very meaningful clinical interaction. You see patients when they have a problem. So you give them access to a way of contacting the service so that they can then be fitted in a timely fashion. I think there's a few things about it. Many services that see patients with long-term conditions have been operating PIFU for decades, but not calling it PIFU. So in my clinic, it's very common for me to say, I will see you again in a year or 2 years, but if you have a problem, then there's a number that they call and then they will be seen. So I think that the patients actually are very, particularly with long-term conditions, are very familiar with the concept of having a help and advice line, and most of our specialist services that deal with long-term conditions have those in place. I can't give you absolute guarantees that they are completely equivalent across the APC, but of course, one of the bits of work that I would hope that we will be doing over the course of the next year will be actually getting into some of this and saying what is the best model for some of these services. At the moment, in order to declare that you've got a PIFU pathway, there's a rather clunky set of things that you have to do, and you have to give a letter to the patient that I am putting you onto PIFU, and which actually may cause more confusion to people who've been on it for years than anyway. So I think that we are probably underreporting the number of patients who are on some form of PIFU, particularly PIFU to follow up.
I think the focus, not particularly for prolonged discussion though, is much more about the patient experience of areas where it's new to it and where we're trying to grow it. I mean, I've just picked up that patients aren't always clear or confident about where they go and do they get a response.
And I think that's probably right. And I think that one of the things that is a concern generally is, have we got structures in place that we're not great at answering the phone.
Yes, exactly.
We have to be better at that. And so when you set it up, you think you have to set that up properly. But they should have proper written instructions about what is the number, what's the email address, and in order to tick the box for new PIFUs, that's what you have to do. So, but I think we will get a better handle on it over the course of the next year.
Do you want to say something about that as well?
Only to say that there are ongoing discussions with all of our clinicians about that communication.
Can I just ask one last question on RTT, and then I'll move on to diagnosis. This may be one for Laura. So we're very close to the target standard, but we've had some conversations about activity levels. How confident are we that we're going to close the gap on that standard rather than drift away from it in the second half of the year. What needs to happen to make that true? Or do you want to feel the chief exec's wanting to have a go at it as well?
Oh, I'll give it a first go. So I think we have plans in each organisation, and we have different targets. We have been very clear at Chelsea, for example, where the target has stretched us much higher than the operating plan we submitted earlier in the year, that will require us to increase the level of activity that we're doing above our plan, and that will need to be funded. So it is a slightly different arrangement in each organisation, taking into account where we have got to in the first 6 months and where we're being asked to get to in the last 6 months.
Thank you. Leslie, do you want to add?
Well, only say I'll ask for very detailed plans for each organisation to say targets are different, but each organisation has, each of the Acute have very good plans actually, including what's the mitigation for winter, because that will be upon us as well. So we have got those plans.
Thank you. Going to move on. Sorry, did you want to add something to that?
Only just to say very briefly that we also use our GPs as very much a barometer, both of good communication, to touch on the question that was asked, and making sure patients have got contact points such that they can contact the hospital and don't have a wasted appointment asking their GP to do something the hospital can do, but also in the context of RTT to understand areas of referral growth. So if we see relatively flat growth over the winter period for GP referrals coming into hospital, I think we're entirely achievable to deliver the RTT weights. Obviously, if we see demand continue to grow, which some trusts are seeing in both advice and guidance and referrals from GPs, we need to understand that and intervene collaboratively with our GP community as a system. And so I think that's one of the risks that we're seeing around RTT, is increasing demand from our GP colleagues.
Thank you. We'll move on to diagnostics. Nick, you wanted to?
Yeah, I mean, I just wondered really, what is the opportunity to improve in this? I mean, in a sense, one is given assurance, or there is a assurance supposed to be taken, that we're now in line with London and national performance. Having said that, we are quite considerably below targets for a number of reasons, which include capacity in terms of diagnostic equipment, I assume, because we talk about the availability of space, but also there are forecast risks in terms of specific treatment areas where there are staff shortages and whatever. And I'm just interested to know what the realistic expectation is to improve and what plans we've got in place. And as we are here as a collaborative, what opportunities are we maximising the opportunity to share across the collaborative in terms of facilities? Because there is a differential between our trusts.
To note that for the past year, we've been slightly better than the London and national performance, and now we are slightly worse than the London and national performance. So, of course, it's a little concern.
Yeah, I mean, it's a good question, Nick. So I think there's a few things that there are major issues with the age of our imaging equipment across the sector. We did submit a plan to the ICB a while ago that would have had a much more strategic approach to how we replaced the asset management. It was difficult to get that business case through the ICB and then through NHS England, so I'm not entirely sure about. And so we have had significant equipment failure in the course of the last year. We have been quite successful in getting money for new scanning equipment that will be in place. So I think that is helpful, and so I would expect to see an improvement from that perspective. We've also, as you probably know, in the community diagnostic centres, been running a trial of very extended scanning times. So scanning till midnight. I have to say I was a bit sceptical at the outset about whether people would turn up. Amazingly, they did turn up, and it's been incredibly successful. So if we can get that commissioned, I think that there is a real opportunity to utilise that. And that's very neat sort of remote scanning. So you don't need to have the radiographer even in the building. It's all sort of Starship Enterprise stuff. You can just sort of do it remotely. So I think there is an opportunity there if we can find a way of leveraging that. There are some areas like, particularly non-static ultrasound and echocardiography, where there is a real issue about staff. And the problem is They are skills that are so needed across all of health, both private and NHS, that the more you train, the more you lose. So that feels as though we're on a bit of a treadmill, but I think we are making progress. We've got things like recruitment and retention premium and that sort of thing place across the APC.
Thank you. Any other questions? Any questions on the cancer section? Yeah. I just wanted to note and congratulate some of the performance around the urgent and emergency care, and particularly Hillingdon, which
It's only Hillingdon,
Lizzie, let me congratulate you and your team.
No, it's not me.
All that reflected. No, but the achievement in Hillingdon to go from where it's been for the last few years to one of the highest performing A&Es in the country is a tremendous piece of work. Alan, congratulations to the team there who've turned that round remarkably, and a tremendous piece of work. Thank you. Okay, I'm going to move us on to finance report. Bimmel.
So the report represents the financial position for the end of August. The actual performance year to date at the end of August was a deficit of 11.5 million against the year to date plan of 5.3, so a 6.2 deficit. In month though, there's almost pushing to break even position in the small actual deficit of 76,000, and against an in month plan of 1.1 deficit. So actually reporting surplus 1.4 variable. All trusts reported favourable variance for the month. Well, the efficiency plan is at 178 billion for 50 years, and that's up 33% from what we delivered in 2024-25, representing a lot higher plan this year compared to last. The efficiency plan in the is adverse to plan operating for 1 million, although we did deliver 14.5 in month 5, which actually is an improvement compared to the first 4 months. So it shows a ramping up of our efficiency programme across the APC. 2 of our trusts continue to accrue ERF income. Year to date, 1.2 million at Imperial and 7, which is totaling 8.2. This is supporting our RTT position, but we'll need to come back down to contractual levels at the end of the year unless other funding comes forward. The forecast at month 5 is still to meet the owner plan at a break even. A couple of things that kept just in terms of workforce. When you compare the last 6 months of 24-25 to the average of the first 5 months, we actually have an overall decrease of 2.1% in terms of workforce. Mainly reductions in temporary staffing for bank and agency. We have implemented our group control processes across the 4 trusts. Substantive hold times are marginally up at 0.9%, but in the main, agency is 1% of our total pay compared to 2% last year, and bank is 8% year to date compared to 10% last year. So those reductions we promised to do. Non-pay, while it's increased marginally, actually in terms of real terms, we've got a real terms decrease of 3% when in fact in kind of inflation. So there's more variable part of the savings programme there as well. Position is just under 300 million across the APC, 35 million higher than the end of March. Cash level is relatively good at 3 of our 4 organisations at over 20 days of cash. However, it's only 5 million west. Our performance against paying off principals is improving at a low levels at Hillingdon and London North West, so they've been improving month on month, even with some cash problems that and the last thing I'll say, the capital spend year to date was 6 million. It is underspent, but mainly driven by some of the national schemes, but we all have plans to bring those back in line. Actually, the monthly rate of spend last month was up compared to the first 4 months, so we can see a ramp up already. So I was going to pause there and just take questions.
Thank you very much. Questions? Comments? Do you want to just elucidate a little more on the cash position? Because it's been a matter that we've discussed a lot, so you ought to just bring it out a little into the public.
Just on the current cash position where we are.
Current cash position and what's at the end of the year.
Yeah, so in terms of it's probably mainly London North West in terms of cash position. With a break-even plan, the cash position will reflect what we started at the end of last year, which is around 10 to 12 million pounds of cash, which is about 3 or 4 days of cash in terms of what we had in hand. We have some options in terms of what Pension England have given us in terms of guidance. One of those is around if you go under 4 days, you can get up to 4 days up, which can only be topped up once. So we have a thing where we can do that. We can enact that. We also have looked at the ICB. We have a longer term. We would need to work for a longer term cash solution with NHS England and the ICB for London North West, because actually just breaking even will carry on staying at the stable position. We need to do a bit more around that.
Excellent. David.
Yeah, thank you. Thank you, Bimmel. Very clear. Just a couple of comments, if I may. I think the APC position on the finances looks reasonably healthy. But we shouldn't be kidding ourselves that underneath that are some individual challenges that we're all focused on and working on, but I just think it's important we clarify that. And also, that was at the end of August, for argument's sake. If we look at the storm clouds coming ahead, I don't think we can assume that our year-to-date performance is necessarily a reflection of what we're going to achieve at the end of the year, unless folks are really going to dial it up, particularly in terms of cost improvement programs, because I think you said the phasing of that. And also, a winter program that frankly is going to be challenging. So I just thought I don't want to, I don't want to lower the enthusiasm of what's been achieved, but I think also looking ahead, we just need to be extra cautious, frankly. Thank you.
Yeah, David, I think that's fair, given that all of our cost improvement programs have a ramp up to them. It's fair to say that a lot of our cost improvements have already been identified and already in train. And if I think about what performance was like last year in terms of how much we identified at this same point, actually we've identified a lot more now than we did at the same time last year. And you can probably see that in some of our run rates and some of the things I've talked about in terms of our workforce reduction, our non-pay. It happened quite early in the year as opposed to kind of the delays. I think that kind of hopefully goes some assurance to the border in terms of where we've got to. But you are right, winter coming, and CIP is one of those areas that we need to keep an eye on.
Thank you. Thank you very much, Steve. Thanks for that, Bimmel. And then moving on to the winter plans, James.
Thank you. As in previous years, our preparations are based on ensuring the delivery of safe, high quality and effective care across our urgent and emergency services during the period that we know will create additional demand from patient attendances. The winter plans for each trust have been provided in detail and they demonstrate clear demand and capacity plans for how we will ensure resilience and safeguard both patients and staff over the winter period. The report highlights the key risks, mitigations and indeed governance where each plan has received detailed scrutiny through both exec and committee structures within the APC. In addition, we did a system-wide stress testing event that presented a series of scenarios, and we looked at how each partner to the winter plan delivery would respond, both including our GPs, mental health, community services, and so on. Key requirements of the plan will, of course, be maintaining safety and staff wellbeing and morale throughout the period, maintaining and improving the 4-hour performance within A&E, reducing the number of 12-hour waits within the emergency department that we see and track through our IQPR performance report, facilitating reduced delays in ambulance handover. And as Sheena said, the collaborative performs very well in that domain currently, and protecting our elective recovery as far as possible, indeed reflecting the conversation that we've had as a board about RTT and our performance expectations over the winter period. We could see additional demand for elective care, but we will see additional demand for urgent and emergency care over the winter period, as we have done in past years. So our everyday focus will be on winter planning and ensuring we protect patients' demand for elective care as much as we possibly can. Risks that are set out in the paper will be not being able to achieve the performance expectation that's required of us, and that crucial 78% performance expectation in March 26. Continuing to reduce the number of temporary escalation spaces and cohorting that is used during times of excessive pressure on emergency departments will be a key patient safety measure that we will monitor throughout winter. Reducing mental health long waits, and we can see the recent addition in our IQPR today of mental health long waits, where we know that North West London is well above the average currently. So there's much more to do to reduce waits for mental health care across the collaborative. Staff sickness will need to be maintained, staff sickness where we can, and our flu vaccine process will be very important over the winter months, and working collaboratively, predominantly with our local authority and continuing healthcare teams to reduce the number of patients who no longer have criteria to reside in hospital, and homelessness will be a particular focus of the work we do in this period. A few key improvements to note from this year's plan. System collaboration is really strong with our integrated care coordination system. That is a service that will be supporting predominantly London Ambulance Service, but also community rapid response teams to deliver the best possible location for the patient's care, closer to home and as safely as possible by triaging calls from London Ambulance direction to remove pressure from A&E departments where that's safe and appropriate to do so. The mental health clinical assessment services, MCAS, a new facility will be stepped up on the West Mid site at Lakeside over the winter period, and we're expecting that to open in December to facilitate a much more appropriate space for mental health care patients to be assessed, reducing that long wait in A&E that we currently see. We have borough-based focused discharge system flow meetings, which Leslie is chairing, attended by all system partners to look at patient flow and reduce patients who no longer have criteria to reside. And all 8 boroughs have now signed off their better care funding process to look at their discharge schemes, which are being maintained. Schemes like bridging to support patients out of hospital before their care can be fully established. Home First to try and wrap around care in patients' home to reduce the demand for temporary or more permanent housing and nursing home arrangements, and Pharmacy First to help patients choose well. So whilst finances are certainly challenged this year for all system partners, we are as well prepared as we can be. The winter plan and all plans have achieved appropriate scrutiny through our committee structure before they come today to the board in common. Thank you, Matthew.
Thank you very much. Thanks, James. Question, Sim.
Thanks, James. Really assuring to hear the differences, I think, in the planning this year versus last year, and that huge system involvement, which has been not as transparent, let's say, as you've just described it. However, I do have a concern because we are at the mercy of the system to some extent. Every year we say winter's is more difficult than last year. And we come up with ever sort of more mitigations to try and manage this with less beds, a staff base that we're controlling from a temporary point of view. So we're congratulating ourselves on one hand that we're, you know, keeping a check on staffing levels, but on the other, if winter turns into a terrible thing, we're going to need to call upon help, especially if our staff begin to get sick and the uptake of the flu vaccine isn't good. So I know it's a bit of a doomsday scenario, but what I'm trying to understand is how confident are we in the system response? Because it's a great list. If anything breaks down or they don't deliver, we're in the same situation again, and we are the last port of call. So I just want a bit more on do they really understand what happens when it breaks down, and what are the ramifications of that? It all just comes back to the acute sector as usual. So a bit more, thank you.
Matthew. So I think we're relatively well tested, and this year has been unique in that scenario planning, stress testing exercise, which was very well supported. Our partners are well used to our cry for help when we need it. That's formalised in operational pressure escalation levels. So the paper talks about OPEL, that ranges from 0 to 1 as a normal system functioning with good patient flow, up to 4 with exceptional pressure. And we immediately get in touch with our partners preemptively when we see those higher levels of internal pressure in hospitals increasing. So they know what triggers that additional input. Their ability to respond to it at pace is often challenging. And I think that is one of the risks over winter and mitigate through collaborative working. My only thing that gives me much more confidence about this year's winter plan is we've done a lot of that work during the summer. So we used to see seasonality that tailed off activity over August and July, and it is much more across the year now. It still increases in winter, but there have been periods over the summer where we've tried and tested our escalation processes, not just as a desktop exercise, but as a real response. So we will closely monitor our escalation framework underpinned by the OPEL triggers, and that links to the range of expectations on partners and indeed across the collaborative around opening capacity, exit strategies from ED that are safe and appropriate, and indeed a focus on the hospital discharge processes to accelerate flow through the hospital. So we're well tested, we've got a set of triggers and escalation processes, and we've certainly tested them in real time over the summer months rather than just hypothetically. So that does give me confidence, but it is still a risk, and you're right to raise that.
Did you want to add something, Leslie?
Yeah, look, it's no doubt it's going to be tough, but there is something that says we've got to be positive about it, and we've got to go in there thinking that we can best experience as many patients as we possibly can, and call the system to account. So the constituent parts of the system being clear about what their responsibilities are, and indeed what our responsibilities are, because there are things we will need to do as well. And I think, you know, can we give you a cast iron guarantee that it'll all be great? No. Can we think that we're prepared about it, and actually we have contingencies when things don't go as they should be, and also how we bring together the system if things get really, really tough, as they might. I think that's where we are, and that bit that says the relationships and the discussion about responsibility are much more upfront now, I think, than they have been in the past.
Thank you. Am I right in thinking that we see flu coming from the Southern Hemisphere, and it's been not great this year in the Southern Hemisphere, so we ought to be on standby for a heavier flu season than we've seen for a while. So I think that patients could most do to help us to go and get their flu vaccinations. Okay, thank you very much. And so I shall move on now to Carolyn and the report back from the.
No, I've got nothing to add to the report. One reflection, however, to our previous discussion.
Every item that we discussed at the committee has either been discussed here or at standing committees. Every single item.
It should be, yes. That's a relief.
Just a comment.
We heard it.
Okay, so I shall move on to the Collaborative Data and Digital Committee. Committee to chair. I think the two things that are probably worth noting here is that we are doing, we did an initial pilot of ambient scribing technology, the ability to use AI tools to take notes in the meeting in order to allow doctors and nurses to spend more time looking at the patient and less time looking at the keyboard. The first pass of that was pretty successful. We tried a number of pieces. Now there is a proper evaluation, a full evaluation going on, looking at the quality and what processes we would need to put in place in order to avoid risk. And then there'll be a business case. Signs are that that is going to be something that we're going to invest in the near future. The other point, George, is that we have worked over the past few years very closely with the ICB. We've had joint digital programs with the ICB. We now need to work out how that plays out following the merger of two ICBs. What happens to that joint working and how it's going to play out in the new structure, which is a question to which we don't clearly have an answer to at the moment. Thank you. Okay, let's move on to Estates, Infrastructure and Sustainability, which I'm going to throw at David. I don't know whether they warned you in advance. Yes. We're going to ask you to role play Bob, but you'd like to role play Bob as he's not with us.
Well, I'll do my very best. So I had been beat up. Obviously, I practiced.
Yeah, very well.
Joking apart, it was a good meeting, and I think it's fair to say it is a committee that initially, when it was set up, said, well, what is our purpose? And now I think our purpose is becoming really rather clear. Whether you look at the ageing estate, how one can prioritise funding across that, and of course, all of the trusts have got some element of ageing estate, but some is just a lot more aged than others. A couple of points to highlight. You can all read the report, but each trust had to refresh its green plan, which it did by the 31st of July this year, not last year, by the way, this year. That's a typo. And I think the backdrop to that is that people are still progressing those well, even though one could argue that politically that slipped down the agenda a bit from a government perspective, i.e. how important is green versus what it used to be. But that hasn't deterred the teams on doing all that work. Excuse me. The other point, it's quite common outside of this industry that when business rates come up to be valued, that people engage independent specialists to really test that. And quite rightly, the trusts have agreed to interpret and get a professional challenge to the business rates in a way that hopefully there will be a lower bill than a higher bill going forward. So that's a worthwhile piece of work to be done. And finally, and arguably the most important, one of our trusts, and it could have been any one of our trusts, by the way, had an incident a few months with a small fire. What that did was really highlight how good we are at being compliant to the various health and safety regulations across. So as a result of that, the committee has set up a piece of work to actually review how compliant we are across our 4 trusts and maintain that going forwards. So out of that, small fire has become a very good opportunity for us to improve. And I think that's all I have to say on the matter on behalf of Bob. Thank you.
Thank you very much, David. Thank you. Admirably done. Okay, can I move on to the APC Executive Management Board and Tim?
Thanks, Matthew. I think most of the things are in the paper, or we've had a discussion about them this morning. I suppose just to highlight the point Peter made about the clinical pathway. So we are looking to make sure that the pathway changes put in place are embedded. But for this year, we also then want to make sure that we have those clinical pathways very much bottom up. We want to make sure that this year we're really focusing on where we see the opportunities are to make the biggest improvements in terms of efficiency as well as quality. EOC, I think, again, patients report really excellent experience at the EOC. I think there is still some work to do to work out how we really make sure that we are filling the EOC from across the APC, and Mark has got that very clearly in his sights. Everything else, I think, we've talked about, except just to note, there is some work going on in terms of ophthalmology to Caroline Clark, the regional director, is very keen to have a single point of access for ophthalmology. London, Moorfields have a single point of access, and we are working with Moorfields to see whether their front door could be an opportunity for the SPOA. I think there are all sorts of complexities around that, around how the private sector has been interacting with ophthalmology. The important thing will be that North West London providers will need to make sure that they are absolutely embedded in how ophthalmology referrals are triaged out to other providers in the sector. So we're working through to make sure that that is a system for the whole of North West London. Otherwise, I think everything else has been discussed.
Thank you. Any questions on that? Thank you very much indeed. Let me move to the executives report then. We'll kick off with Trish.
Oh, thank you. So many of the things we've talked about during this meeting, but there's a theme in both the reports, both for Chel West and for Hillingdon, which shows we've spent a bit more time actually trying to recognise some of the special work that both individuals and teams do. And I know the staff like to read that. They like to know what each other are doing, actually. And we spend a bit of time now in the team briefs and the webinars, allowing teams to present that work. So that's been a thing that's been really special. We did the Cares Award. We do Proud Awards at Chelsea. We do Cares Award at Hillingdon. Hearing staff talk about their experience, what their colleagues say about each other has been something pretty special. Just you started the meeting, Chairman, with the celebration of Diwali. It's also Black History Month, so we're doing a lot of work around that. So it's been lots and lots of work, always more to do and improvements to make, but some great stuff going on in the organisations.
Thanks, Leslie. Questions? Good, thank you.
Thanks. I'll take the paper as read. I won't cover operational performance because we've covered that, but just a couple of staff bits. So we set a headcount reduction plan, as you'll see from our financial plan. We have just closed 9 consultations that have been live. So it's been a difficult, turbulent time, I guess, because change does cause anxiety. Our biggest consultation was redesign of the organisation. So moving from what was originally 6 divisions is now 3 divisions. And James has done a great piece of work leading through that did result in compulsory redundancy in some of our senior leaders. So that has now just gone live, and we're now set up as 3 divisions, and we'll support them divisions to function the organisation. We also ran a mutually agreed resignation scheme, a very short scheme. We had over 55 applicants. We accepted 29 applicants, which has contributed towards our headcount reduction as well. And I suppose the last thing I'd say is around the culture and the global civil unrest that we're seeing is causing anxiety with our staff. We've had some very difficult messages. Comms have done a great effort to try and communicate with our staff appropriately. We've got a unity event, actually a listening event tomorrow, which is really important, and they're really important within our organisation and our staff to just speak about the concerns that they are feeling living within some of this unrest. So I think it's just important we pay time and effort to that. We had our CQC inspection unannounced on the 15th of July of our emergency pathways. We await that report, but nothing urgent was told to us. Just a couple of recognitions. We are officially in the Guinness Book of Records. So Beryl Carr, who's one of our volunteers, she's absolutely fantastic. She is the world's oldest female volunteer. And at the age of 103, she still volunteers once a week in our Friends Cafe. She's absolutely fantastic. It's like she is the star of it, which is amazing. We've done some other work around closing some of our services, which I know hasn't been popular, but these are services that shouldn't really sit in an acute trust and are not funded within an acute trust budget. One of them was our hydrotherapy pool. So lots of engagement, patients and staff around the closure of that service. And just lastly, then a couple of recognitions. So our tissue viability team won the HSJ Patient Safety Award. That was for their skin tone assessment tool that one of our tissue viability nurses has designed. It's got so much national recognition. It allows you to truly inspect skin that could be at risk of pressure ulcers for our diverse population. So really important for our populations, but really has got a lot of great recognition and deservedly won that award. And we've been awarded the highly commended for best peer-to-peer support within the trust, and also the menopause friendly accredited employer of the year as well. So some great work from our occupational health teams that are doing lots of inclusion and supportive work around our work.
Pippa, any questions or that? Thank you very much. And Tim.
Thanks, Matthew. I think most of the stuff is in the report. We did see a busier than expected summer in terms of A&E attendances. So they were up 4% on 22-23 and 3% on 23-24. So a bigger increase from last year compared to the year before that. I think just to highlight some of the things that my colleagues have mentioned. So I think the issue about keeping our staff a cohesive group is incredibly important. There's obviously the issues with strikes, but I think the external situation has been problematic. We've had a full programme of diversity festivals noted, so Asian Heritage Month, then Black History Month, and we just launched a faith and belief network. I think it's quite helpful because I think a lot of what we're seeing now is that lack of understanding, that lack of being prepared to engage on some of these quite tricky issues. So hopefully that will be helpful. And we've also managed to get some money, £50,000 from NHS Charities Together to support the rollout of cultural intelligence training, which I think is really helpful. And I think there's a lot of evidence now to suggest that is a more beneficial form of training than the sort of inherent bias training, unconscious bias. Thank you, Kevin. Old age. Anyway, so I think that is important. Just to note to Mary's redevelopment, we sent out some notes to stakeholders this week. Simon Blanchflowers as the new external chair, independent chair of the task force that we set up with Westminster City Council and with our local MPs to explore how we can try and access new methods of funding for a redevelopment of St Mary's, because we do not believe we can sit here and wait till 2040 to get a new hospital. And that ties in neatly with some work that Jim Mack is supporting and that Bob Alexander is also supporting at the national level with NHS England. As you can see, lots of nice recognition of many teams' contributions to thinking differently about the way we provide care and the recognition celebrating success. And could I just finish by reiterating your thanks, Matthew, to Helen for her contribution to Imperial. I do think...
and show us.
You should have mentioned it. You didn't mention it. I do think if you sit as a chief executive, actually, you know, the perfect non-executive is somebody who is supportive but challenging, and I think you've fulfilled that role incredibly.
Working the challenging but brief, I think is what you usually say.
Unlike me, yes, I'm doing.
Thank you very much, Tim. Any questions for Tim?
Another question at the point. There's a bit of work going on across government on impact funding, which has got some traction in Treasury, and it's about how do you, and part of the key thing they're looking at is how do you have the HMT rules which stop you really doing anything. So just so you know, there is some work happening that's a bit outside the NHS. I think there is some interest in from the NHS in that.
It's really helpful to know.
So I think it's just a bit of a drumbeat happening.
Now that's helpful because when we met the minister to talk about St Mary's and the task force, I think he clearly gave the civil servants a very clear steer about you've got to go away, and this has got to be a cross-governmental approach about, as you say, how do you get impact across growth and safer streets and all those other branches. Thank you.
Thank you. Thank you very much. I think I'm now at the point of asking whether there's any other business.
Actually, no, you didn't. They're on the agenda.
Oh, sorry. I was getting too excited.
I was
Yeah.
really happy with you finishing.
Sorry. Yeah. No, I thought we did. No, you are completely right. And I just a moment. Overexcitement. Sorry. Let us do the reports on the standing committees, and let us start with the London North West one.
David.
So, to be honest, I don't have much to cover other than the fact that the topics that are discussed at those meetings are becoming increasingly important, and we need to ensure we're allowing valuable discussion. And there is a risk that the agenda gets compressed because of time. So one of the things we're going to do is extend that, not for the sake of it, but where relevant. If they're meaty topics that the whole trust needs to understand, then we will make sure we've got time for them. That's probably the only bit I want to cover. Pippa, anything else you want to do?
No, nothing else.
Thank you very much, David. Hillingdon.
Yeah, so I did want to raise the issue that we have as a standing item on our standing committee now, an item, we put it under the title Hillingdon Health and Care Partnership Transformation, but it's really about a left shift.
Yeah.
And I think it would be really helpful for us to have strategic cross discussion at one of our future board meetings about that left shift. One of the real challenges we're all going through, and I don't think it's just us, I think it will be nationally, is what is the performance data that sits around that tells us what investment creates the greatest benefit. And I think that's something that we should be discussing as well. So that's just passing on. That's something we've started doing in Hillingdon. I think it'd be good to do it across the piece, really.
No, I think it's a very good point. It's very useful. I think we have 2 of the neighbourhood national pilots are in the collaborative. One of them is Hillingdon, and the other one is Kensington and Chelsea. So
and Westminster, yeah.
Borough, is it? And Westminster. So we should. I think we should talk to our partners and think about bringing that discussion to. Thank you very much indeed. Fabulous. So.
Shall I pick that up?
Please do.
I just would pick up a couple of things, and maybe colleagues can help me if I get this wrong, but I think we had 2 really good deep conversations in this ICHT. And that was West London's Children's Healthcare. The managing director of that service came to talk to us, and I think we identified an opportunity across the group with regards to children and young people in West London. So that needs to be picked up perhaps strategically at group level. The other conversation we had was North West London Pathology and the service that they deliver. And again, that's strategic outline for the future. What does pathology look like across our if you like. So I think there's a probably juicy content there to be discussed further for great opportunity.
Yeah, very good.
The West London children's bit was great, and we did a walkabout afterwards. And one of the things that jumped out loud and clear was that the governance doesn't work into one. Well, basically, I don't want to misquote them, but they felt like they're reporting everything twice, etc., etc., etc. So it just felt very strongly that there were some really, really good lessons to be learned from their experiences.
Right, so thank you. So, West London Children actually services children at Cyril and at Chelsea. So I don't think we've heard them say the governance doesn't work. So does it mean that sometimes you have two places to go, but so do many of us, is all I would say. And, I would say that part of that is, and by the way, we've made the introduction of Hillingdon already in terms of bringing that together. My feel is that we can make the governance work. What we'll do is make the service work for children. And I think, so we'll take away definitely what it is around the governance that doesn't work and the lessons that we've learned from places like people in HR and things like that, that says actually you can make governance, it's not always easy, takes a bit of effort, but being asked to talk about your services to the organisations and the children you serve, it's part of something all of us have to do.
I think that's what they meant to all. So don't take it away that they were making a complaint. They weren't doing that. What they were saying was that they do a lot of things twice. And is that really necessary? And if we wanted, which sounded possible to me, to make that work across the piece, they certainly don't want to be doing lots of things 4 times. So I actually think it's used. I think it's really important that they feel they can raise things like that to Neds.
No, absolutely not. I don't think it's only, I think what I've said is we will take that away and have a look at, because they haven't mentioned it, is what I'm saying, is if there's an issue, let's take that away and have a look. Anyway, Tim will solve it now.
I suppose does it work? Yes. Is it optimal? No. I think it's probably the issue. And when we all knew when they set it up that they were going to have to report twice about something, because there was no, when we set it up, there was no actual governance framework that would allow us to pull it together. I think the opportunity, as we had in that conversation, which I thought was a very good conversation, is that there is now an opportunity, because we've got West London Children's having a unified view across 2 of us, with again now bringing in a 1/3 of the trust. There is a question for us of what does children's health look like across the whole of the group, and that is a real opportunity. You're absolutely right. What we can't then have is one service across the whole of the group reporting 4 times, and it will be a really helpful thing for us, of course, because then I think we can work out what could the structures look like across the whole of the group for a single specialty. So I think it's an opportunity.
It's fair to say that the conversation was about how does it move from being West London Children's Inner to being West London Children's, rather than the government's part of it. Lloyd.
I was on that same walk around, and we reflected later that it was actually quite a good pathfinder group to work out where we might find some of the stumbling blocks to working as a group, and then find early resolution.
Thanks for that, Lloyd. Thank you. And then I'm on to Pat and Cheltenham Westminster.
Are you able to update on this one as soon as how you chaired the meeting for me, please?
Oh yeah, I chaired it, didn't I?
Memorable, was it?
I'm so helped.
You look very good notes, though.
I wrote very good notes. I do have the notes somewhere. Yeah, we did have an excellent meeting, as we always do. The key points that we raised were around the developments that were going on around management of mental health, the use of virtual wards, and the redesign of services in the run up to winter. And we had a conversation about the board assurance framework and the way in which we were undertaking oversight. I think those are the key points. Anything you wanted to add to that?
No, I think that was it actually. No.
Very good. Okay. Can I move on to any other business now? Is that be all right?
Answer.
Thank you. Is there any other business? Thank you very much indeed. In which case we have a little time for some questions, and I will take. I hate anyone thinking that I'd lost a grip on the meeting. Yeah, I've got Robin. Thank you for raising your hand. We have your set of questions that you've submitted, and we will take your suggestion, pick up questions 5 to 11, and respond to those in writing. Why don't we take the first of your written questions, Robin, if you want to outline it, and then I'll come to Armel, and then if there's no other questions, I'll come back to your second one. That's all right, so that other people get words in each way as well. So, Robin, do you want to highlight the first of the questions you submitted?
Thank you, Chair. I'd also like just to say that the Brent Patient Voice questions are compiled by Gaynor myself, and Gaynor's in the meeting, but she has difficulty with her computer mic, so she should get the second bite for Brent Patient Voice, if that's okay. But I'll start with question 1. I'd like to thank, of course, all the work that's represented by those at the board today. We do appreciate the enormous efforts of the staff of the the collaborative in the circumstances. It is tremendous, and we're very sorry about the issue you raised about the abuse of staff, and anything we can do to help in that area, we'd be very pleased. So my question really about what is the new role of the ICB? I mean, in our case, merged, but it doesn't really matter whether it's merged or not. The ICBs is facing 50% staff cuts, and we're told they have a new commissioning role, a strategic role. And I'd like to ask, what difference is this role going to make to the hospital trust, the collaborative, because we haven't had any explanation, what strategic commissioning really means in the new context. And we note, of course, that between North West London and North Central, there is a difference in the allocation per head of resources. And we'd be very pleased to hear what's happening about that, because it's obviously very important for North West London people. Thank you, Chair.
Thank you very much, Robin. Leslie, do you want to have the first crack at that?
Yeah, so thank you. Thanks, Robin. So I think in terms of the role of the ICB, it's a developing role in terms of setting the context around population health and the strategic commissioning of appropriate services, both in and out of hospital, which in and of itself sounds like just a sentence. I think there's work to be done with the ICB and the ICB leadership about what that means and how we translate the national operating plan into delivering that. So, but it's so early days on that. In terms of the question about funding, so the chief executive of North West London have written to London and the national team asking for clarification on that. We know we're an underfunded sector, but we know that North Central are on the current allocation formula are overfunded. We know that the chief executive of the NHS has been clear that he would wish to accelerate the move to proper fair shares and people getting their proper funding. So we've written on that basis, and we're in discussion with them about what that means and how we will ensure that we do our best in terms of the allocation for the people of North West London.
Thanks, Leslie.
Thank you.
Yeah.
Sorry, is it me, Chair?
Yes, please.
Oh, thank you very much indeed. Well, a lot has been said about Hillingdon today. All was good news. So why do we not receive any newsletter? Regarding the deprivation in Hillingdon, I wrote a letter to Dr. McLennan and to our MP asking for a meeting because the Heathrow villages do not have any GP services or pharmacies. And they were in, I think, 2019, they had 32 or 33,000 attendance at A&E because of the lack of services. And I would like to sit down with our MP and THH, either Dr. McLellan or Leslie, to actually see where we can go, because there are going to be some improvement with the Heathrow villages, but the hospital has got a great part to play in it. And what I wanted to know is, with the new ICB, are we going to get more hospital in this group? And finally, to the chair, you have a lot of, or a few very dedicated members of the public. And I wonder if you consider putting them on the list of people who attend, because I've noticed that members of the public are not on the attendance, which is very sad. Thank you.
So in terms of the newsletter, Arnell, my apologies. So we will address that, and we will make sure that our members are kept up to date. So we will absolutely do that. In terms of the work around general practice and the impact on the emergency department, as you know, with Hillingdon Healthcare Partners, Alan might want to say a bit more about this, but Hillingdon Healthcare Partners, indeed with the ICB and with the local authority, the Health and Wellbeing Board, we're looking at how we improve those services outside of the hospital, both because that's better for our patients, but also to ensure that we right-size the new hospital build. So we're working hard at that, and we will make sure that our communication outside of the hospital is better.
Thank you. Just on last, obviously these meetings are public meetings. We advertise them publicly. The date of the next one is listed here, and anyone can join. We don't invite people, especially actually the link that you've used. If you want to share it with any of your friends, any of them can join. Pete, do you want to add to that?
Yeah, I think Mel's point, I think, is do we record the people who attend here on our minutes? I think your point is.
I think the question was about inviting people.
No, no. Sorry, Chair. Sorry, it was actually the attendance. When you have, I've got the printed papers of the agenda, and you actually list the members of the board, but you do not list the member of the public, and you have very few members of the public who have attended those meetings for many years and worked very hard for their communities. And I think it would be recognition, and I can see there are members of the public behind you, but there are only 4 or 5. A page could be actually given to them to give their name. I think it would be nice really to recognize members of the public by listing them on the agenda when you actually write the attendance of the board. Thank you.
So just on that point, so as you said, Matthew, so this is a meeting of the boards in public. So from a governance perspective, we need to record the members of the boards who participate in the meeting. That's not to say we don't recognise, Amel, the amount of contribution that we have from members of the public. So those of you who raise the questions, we do credit that in terms of the Q&A. So we record who's raised the questions and the responses that we give to. I don't think it's not necessarily fair to record everybody who attends this meeting in terms of members of the public, because they may not want to be recorded anyway. And actually, it's not, from a governance perspective, we need to only record board members. But we will ensure that we give due credit to those who contribute to these meetings.
Thank you. Gaynor, do you want to pick up the second of the Brent patient voice questions?
Chair, the problem, Gaynor has a problem with the mic on her computer, so she asked me to ask the question for her, if that's all right.
No, that's fine. It's just Gaynor had her hand up.
Yes, I think she has, unless she comes through. I don't think she. So the question 4 in the list we submitted, rather long one, I know, long list, but we're very concerned about the interaction of the acute provision with the mental health issues. And there are various mentions in the papers of difficulties because of the lack of interaction, and mental health still seems to be the poor relation. And it's hard to find a champion for mental health in the top leadership of the NHS. What can the collaborative do to encourage the mental health side, or the government to fund that side properly and to make adequate provision so that, those patients can get the best service, and also that mental health patients are not making it harder for the routine collaborative to, do their work for patients. Thank you.
Thank you.
Thank you, Gaynor and Robin. So obviously, we can't answer for the accountability of the Mental Health Trust. However, we work very closely with our CEO colleagues across the system and have many conversations about mental health, particularly the pressures it causes in our A&Es. Mental health, you've alluded to, have closed beds in North West London. However, they have opened many other schemes that are about preventative crisis. So we're now looking at having mental health practitioners in every school, in every community, really trying to prevent that crisis point that then does impact care in an acute trust. So there is lots happening in the mental health space, and you're probably very welcome to attend their public board where they would allude to some of that. We've also got a mental health crisis service about to open in December on the West Middlesex site at Lakeside, which will really help the provision of patients in our A&Es. So I wouldn't just take it that there is closure of beds, there is opening of other services as well, and we work very closely with them on that.
Thanks, Pippa. Gaynor, you have your hand up. Have you cracked the problem with your microphone?
Oh.
No, well, probably we have time to pick up about 2 questions. Do you want to do questions 2 and 3?
Yes, thank you. Well, the question 2 was about PIFU, and that has been touched on this morning, helpfully, I think, but I think there's a long way to go on ensuring that patients in this situation get the relevant letters from, that GPs get the relevant letters about patients on that kind of arrangement. And I think Gaynor's had direct experience of it this morning at Northwick Park in practice, so it's very live. But I would just like to draw attention to an issue that was reported in The Guardian on Saturday, where there's been a national FOI about maternity services and 14,000 patients who had to return after giving birth to the hospitals for further care. And a number of very unhappy incidents related to that. So could we ask for the relevant figures that have been amassed nationally to be given for each of the maternity trusts represented by the collaborative, and maybe come back at a later stage, because I don't think those numbers appeared in the relevant pages on the maternity report 80 to 84 or something like that. So it's about patients who have to come back after giving birth, and often with very unsatisfactory results. I'm very sorry to hear about that. Thank you.
Thank you. Pippa or Robin?
Thanks, Robin. So I know that looks like an alarming number, but remember there's many births across the country. It actually equates to about 3.1% readmission rate nationally. In North West London, we've got a readmission rate lower than that. It actually sits about 2.6% currently. Just remember there are many reasons why people will come back to maternity that are positive reasons, so that we encourage them to come back if they're struggling feeding their babies, or it's not just about the mother, it's about the baby as well. So the reason for coming back is quite often a supportive measure. We do look at all our readmissions. They are all day-text into our clinical incident system, and we look at themes and trends from that. So it's not a concern for North West London. It's not an area that we outline or we have concerns about.
Thank you very much for that. I am going to, I think, wrap the meeting up at that point. Thank you so much for joining. Thank you to the public who joined us online. Thank you to board members. Have a good day.
You have to.